Good afternoon, and thank you for joining us today in this Image Challenge live stream event from Retinal Physician. My name is Marianeli Rodriguez, and I'm a retina specialist with Vitreoretinal Associates in Worcester, and I practice in Massachusetts. I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform, and we would love to hear your chats and your thoughts online. You can find us on Facebook, LinkedIn, YouTube, Instagram, and Twitter. And you're also welcome to write on the chat and share your thoughts with us during this event. And I'm joined today by Dr. Danny Diaz from Retinal Consultants of Miami. And I know Danny from way back when he was a resident at Mass Eye and Ear. I was a Retina fellow there. And then he went back to Bascom Palmer to do his Vitreoretinal fellowship training. And that's a place that is dear to my heart because I was a resident there. So I guess we switched. So welcome, Danny. So nice to catch up with you.
Yeah, likewise. Thanks for having me, Marianeli. Happy to be here.
Yes. So I want this to be a very dynamic discussion. I want to pick your brain on the management of a condition that we all face as retinal specialists. And the diagnosis here is not a challenge, but the management is always challenging. So this 90-year-old gentleman presented to us with an episode of sudden vision loss, and he was already established with our practice. And we were seeing him on a yearly basis for dry macular degeneration. And he came to our clinic for an urgent visit. He had normal intraocular pressures, normal anterior segment exam. He's pseudophakic. His vision was hand motion. So I have the fundus photo here. So if you can just walk us through this and just tell us your impressions.
Yeah, so, it's a pretty significant submacular hemorrhage. It looks like, I can't really tell in the photo, but it looks like it's mainly subretinal. There could be areas that there could be some RPE blood as well, and maybe a bit of breakthrough as well. But certainly a pretty large and dense submacular hemorrhage in the patient's right eye.
Yeah, so I agree. And, you were talking about whether it's subretinal or preretinal. And I remember as a resident that, this was an important distinction and just always good to look at the vessels and follow those to think about that. So if we move to the next slide, we see the OCT, and here we can tell a little bit where the layers are. And what do you see here?
Yeah, I mean, there's certainly a lot of intraretinal fluid. Also, there's some subretinal hyperreflective material as well. It looks like, pretty poor quality there, but it looks like there could be sub-RPE elements as well.
Yeah, so yeah, this was pretty massive. And the poor guy was, very distressed. He's like, oh my gosh, this came all of a sudden. I don't know if you can save my vision. So what are your thoughts about this? So we know it's subretinal hemorrhage. He had a hemorrhage from, from conversion to wet AMD. So I guess, what are your thoughts? What do you do in clinic? Do you offer surgery in a case like this?
Yeah, these are, like you said, very tough and dynamic cases that we face. I think that a submacular hemorrhage, the most common cause being AMD, and in this 90-year-old, I think is consistent. But like you said, there's other, potential reasons to have submacular hemorrhage. So making sure you think of those is going to be super important. Some clinical points I like to focus on, certainly age of the patient, comorbidities. What's his medication history? Is he on anticoagulants or antiplatelet therapy for any other possible issue? You want to talk to him and get details as far as the HPI is concerned. How long has he had symptoms for? Is this a fresh hemorrhage? On the exam, is there areas where there could be signs of older heme or dehemoglobinized hemorrhage? In terms of management, I think that really is going to depend on the patient and their wishes. First thing I would tell them is that this is an extremely guarded prognosis, regardless of treatment approach that you would decide to do, and making sure that they fully understand that, I think is important. Management, in my opinion, I think is going to be guided by thickness of the hemorrhage, location of the hemorrhage, whether, like we said earlier, is this subretinal or sub-RPE. I think that surgical therapy is less indicated for sub-RPE hemorrhages just because of difficulty involved. In this patient, I think that it looks like it's certainly a very dense and large hemorrhage. I think that intravitreal therapy with anti-VEGF agents as monotherapy is probably not going to be potentially as successful as surgical therapy. And whether that's, in-office procedure, as we'll discuss, or in the OR, I think I initially would lean more towards surgical intervention here, if the patient is motivated, of course. Um, and I would pose all three options: injections with anti-VEGF, surgical therapy with subretinal TPA, and gas insertion, and also in-office therapy, which I haven't personally done, but pneumatic displacement is a possibility as well.
Yeah, so those are really great points, and we'll get into each of them. But I'm really glad you brought anticoagulation, and that's something that a lot of patients, that we see with this have. He himself was not on anticoagulation, but a lot of them are on Coumadin. Eliquis is a common one, Agranox. So, a lot of them come to us and they said, "Oh, should we stop our anticoagulation?" Moving forward. And I always tell them, if we're thinking about surgery, yes, but moving forward, no, because, the eye is a secondary organ. You cannot function if your heart, or if you have a stroke, or, if you have a PE or whatever, and we can manage your eye locally. So I always tell them to continue their anticoagulation, in the future, and that we can, manage the eye. But I have had these questions even from primary care doctors. I don't know if you've encountered this discussion as well.
Yeah, it's tough. If possible, I like to stop anticoagulation pre-op, of course.
Yes.
In some cases where it's impossible to do it, I think that, this goes into a whole larger discussion, but I
Right.
think retina surgery nowadays could be done mainly, pretty safely in patients with anticoagulation, but just warning them that they could bleed more and this could be prolonged, I think is important. But yes, I oftentimes have to discuss this with PCPs as well, cardiologists as well.
Right, right. So having all the whole team involved is very important. And what you discussed, being very honest with the patient, talking about the guarded prognosis of something like this, even if we can improve things, things are never going to be the way they used to be. And just having that expectation from the get-go, I think really helps everybody be on the same page. And if they can have another family member listen to this discussion, it's also helpful, because I feel like when they're in such a hard situation, they may not be hearing everything that you're saying 100%. They just lost a lot of sight, and so they will just hold on to the hope, and sometimes might not be hearing that this is guarded regardless. So let's talk about we posed a question to our viewers, and we had a poll on LinkedIn, and I was surprised a little bit by the results here, because most people said that they would do PPV with subretinal TPA, but only 21% said that they would do both intravitreal injections and surgery, which would be what I expect most people to do. Would you ever go to the OR without doing anti-VEGF therapy, Danny?
I think, yeah, it's a good question, right? I think that if you're planning to go to the OR and you can't go, of course, same day or maybe even next day, I think doing something in the clinic to at least maybe get something going, probably with intravitreal anti-VEGF injection, I think makes sense. In that case, during the vitrectomy, washing everything out, I think I would probably always lean on just giving another injection as well at the end of the case. It's so easy to do.
Right, right. And then in terms of your choice of intravitreal injection, do you have one that you go to right now when you see a massive subretinal hemorrhage like this?
I wouldn't say I have one particular one that sticks out to me. I think aflibercept probably. I probably would start with that, easiest available in my case. But newer agents with faricimab, I think it would also be a good idea. And then interoperative, whatever the ASC might have. My ASC would only have bevacizumab, so I'd probably go with that at that point.
Yeah, so I agree with you. I would probably do aflibercept or faricimab, and in the clinic, I would, because probably most likely I would not be taking this patient to the OR the same day, just given clinic flow, etc.
Yeah.
But I would try to do it within 3 days or so, and. So just talk to me about, if you were to do the patient in the OR, what's your approach? what's I usually do a TPA dose of 0.5 milliliters for 50 micrograms. And then, I order that in advance to make sure that they have that in the OR. And that sometimes will dictate the OR where I will go. I usually operate in 2 different ORs. So in one of the surgical centers, they don't have TPA, and I have to you do it in the, bigger UMass center.
Yeah.
So that's another consideration for surgeons as well.
And remind me, you said you used, what was the dosage you used?
I use 0.5 milliliters per 50 micrograms. So,
Okay.
and
Yep.
then when I go in, we were talking about it before, and I operate by myself. I don't have fellows or residents with me. I have a technician, which, the technicians that operate with us are amazing. They really are very helpful. But, during the time of the injection of the TPA, I would love to hear your thoughts. But for me, I do usually I do the viscous fluid injector, and then I put a 41 gauge cannula in there. And so that's what I use to go in to do the actual subretinal injection. And then I use very low flow rate, like 6 or 7. And I feel like that's just very controlled injection, and I don't have to be really nervous about somebody just pushing in really hard, and somebody that may not have the training. And we also don't do these cases that often too. So because of that, just gives me
Yeah.
control. So
Yeah,
I
that
don't
makes
know
sense.
what your thoughts are about that.
Yeah, I think surgical approach to this would be, pretty standard. In my case, 25 gauge setup. Go in, core it out, lift the hyaloid if it's still down, being very careful. I have 41 gauge cannula, I think is perfect here. And I think your idea of having on the viscous fluid control setting, I think makes sense. I personally also prefer that. And it's certainly very controlled. There's a couple of providers, I think. Med One has a nice cannula, and also Dutch Ophthalmics also has another 40 gauge one as well. As far as the concentration, I think that's pretty standard. You can fill up a 1 milliliter syringe with 100 mics, and then just kind of use that. And in terms of approach, certainly avoiding sub RPE hemorrhages. I tend to want to go superiorly. Go in, create a dimple on the retina, and then just advance a bit more slowly and until you get to the subretinal space. Create a nice bleb. Some people have described also inserting gas to kind of help disrupt the clot a bit and to help the TPA kind of do some work. I haven't done that myself.
Yeah, I've never done that.
And then once you have a nice bleb, finish the rest of the peripheral bit. And then in terms of gas, I'd certainly like to have some tamponade. I'd prefer some gas over or SF6 over air. And I think a 50% FAX, I think is good. Some people have described, and I think we'll talk about one of the papers that did a full FAX. I think that's okay, but really my goal here is to try to displace any heme away from the fovea as much as possible. And I think having some gas come from the top and kind of maybe try and displace downward and put the patient to sort of maybe a 45-degree, some people describe it like a bird beaking angle, just to kind of help maybe put some downward pressure on that area of heme. I think if you do a full air exchange and put them face down or something, I think you might get a more larger area of dispersion. But, it's hard to say whether one's going to be more effective than the other. I think it's just what's best in your hands and what you think might work. But I do a 50% fluid air exchange and do 20% SF6 and put them at 45 degrees.
I basically do what you do. I do have them right after surgery. I have him kind of be on all the way on his back for about an hour, just so that the TPA can just kind of hang out there in the macula. I'm not sure if it's going to be that helpful, but that's what I do. And then I have them with that 45-degree prayer angle. That's the way I call it. And then I have them like that for 3 days. And I also do a partial fluid air exchange. I don't do the full in this case. And then we were also talking about, and we put it in the LinkedIn poll about pneumatic, whether, some people would do pneumatics for displacement, with SF6, usually in the paper that was recently published in ophthalmology by a French group, they describe about 0.3% of pure SF6 injection in the clinic, and then having the patients with like that 45-degree angle, and also injecting intravitreal TPA. I'm not really sure, and I've been trying to think about how the intravitreal TPA would really help this, because like, how is it going to go where the clot is?
It's a good question. I mean,
Yeah.
I actually looked it up. It actually is from a molecular sort of weight perspective. It's actually less than Eylea, for example, or
Okay.
aflibercept. So maybe there's some transretinal, you know,
Some of it will get there
that
somehow.
way. Yeah,
Yeah.
I mean, I guess it's better than nothing. And
Yeah.
if you have it available in clinic right away, I think it's worth a try.
Yeah. So, because a lot of these patients, he's 90 years old and he was healthy otherwise. And so he had no really comorbidities or any other problems to go and to do surgery right away. But, what we talked about some patients that are on anticoagulation, I would be very hesitant to do surgery on a patient that is on anticoagulation, especially with this. So I think the pneumatic would be a good, potentially something in clinic that might be good for, those patients that may not be able to go to the OR because of comorbidities, etc. And it's not something that I've done, but it's something that I will probably consider in the future. Because, in that paper, they randomized 90 people, and at the end, they have similar visual outcomes. And so it's something to consider. 16% of our the people that we polled said that they would try that. So I may try it next time.
Yeah,
And
I think it's
in the right patient, if we're not able to go to the OR.
right. I think it makes sense. I have some Canadian colleagues that I think really kind of rely on this a lot, in areas with poor access to the OR, for example, or, they have a lot of course, experience with pneumatic retinopexies to begin with. So I think
Right.
for them, it's a pretty easy run of the mill procedure. And, they probably, the 0.3 versus 0.6 SF6, I think it just depends on the volume. I mean, if you're injecting VEGF and TPA,
Right.
it's just a lot to deal with. But I agree. I think it's a great option.
Right. Yeah. So, and then in this paper, they injected, when they randomized the patients, they injected ranibizumab at the end in both cases. So, and that kind of takes us to what we were saying, that regardless, we will probably treat with anti-VEGF moving forward anyway. And I just want to show the images for my particular patient. A month later, we were able to, displace most of the hemorrhage. It was inferior. And then you can see the OCT significantly improved. There was still, that big membrane there that was not be able to get displaced, but his vision significantly improved from hand motion to count fingers. And he himself reported a significantly improved vision quality, especially in the periphery. And he feels that he has useful vision now, which he didn't have prior to the surgery. So, even though he still count fingers, I still count this as a success. So, and for him, I still need to inject him every 5 to 6 weeks. This happened a year ago, and I still see him every 5 to 6 weeks. And now I'm injecting him with faricimab. I'm not able to extend him because every time I try to extend by 1 week, he reaccumulates fluid real quickly. He has a very aggressive form of the disease. So this is my experience with him.
Yeah, it's a great case. I think it's a great outcome. And I agree. I think these patients probably benefit from monthly VEGF treatments, and especially in the short postoperative period. I think the risk of recurrent bleed is probably higher in these patients. So I think trying to keep things at bay is worthwhile.
Yeah. Anything else that you think we missed in this discussion? I think we covered a lot of ground in very short time.
Yeah, no, I think it's a great case. I think that once again, the most important things are probably going to be, large, dense, thick hemorrhage, right? I mean, thin hemorrhages, which we see much more frequently, I think probably do better with intravitreal monotherapy. And it's interesting to think about that we actually don't have good data as to how intravitreal monotherapy would actually do in these patients with large submacular hemorrhages. So we actually don't know what it would look like. I mean, we can hypothesize you're just going to have a huge scar there, right, from the heme, but none of the initial AMD trials actually used intravitreal therapy, and they actually excluded patients with large submacular hemorrhages. So it's just something to think about. But I think that surgical approach has a good role here.
No, I agree. And that was great, Danny. Thank you so much for
Thanks so
your
much for having me.
input. And
It's great.
thank you, everybody, for tuning in today. And you can leave us a comment via multiple platforms. And we hope to see you again in a month to
Take
discuss
care.
more of this.